This video will show the surgical technique of transabdominal cardiophrenic lymph node dissection for cytoreductive surgery in advanced ovarian cancer. Informed consent was waived by the Institutional Review Board for follow-up loss. This is preoperative CT scan images. There was no sign of internal mammary lymph node enlargement. However, we can see right anterior cardiophrenic, right lateral cardiophrenic, and right posterior cardiophrenic lymph node enlargement, as well as left anterior cardiophrenic lymph node enlargement. Right anterior cardiophrenic lymph node dissection was performed through the subxiphoid approach. We used the plane between uterosternum and peritoneum. Cardiophrenic lymph nodes and pericardial fat were dissected together with saving the right phrenic nerve. We can extend the subxiphoid incision laterally without injury of the diaphragm for obtaining a sufficient visual field. Right anterior pericardial fat tissues containing anterior cardiophrenic lymph nodes were dissected using an energy device. It is recommended to start from about 1 cm above the phrenic nerve and also be careful not to injure the underlying pericardium. Right lateral cardiophrenic lymph node is located just on the inferior vena cava. For safe dissection, silicone-based flexible retractor is useful to expose the lymph node by softly compressing the right heart. You can see the mildly compressed heart by the flexible retractor. For left anterior cardiophrenic lymph node dissection, the similar subxiphoid approach was used. You can easily extend the subxiphoid incision to get a good surgical field. The left phrenic nerve seems to be located on the more anteromedial side than the right phrenic nerve. We should preserve it. So the left cardiophrenic lymph node must be dissected after checking the course of phrenic nerve. It is important to have a good view by gently retraction. Left anterior pericardial fat tissues containing left anterior cardiophrenic lymph nodes were dissected together using an electrocautery and energy device. You can see the left phrenic nerve. We need a different approach for posterior cardiophrenic lymph node dissection. Firstly, triangular ligament is divided and retracted laterally to expose the esophageal hiatus. Esophageal hiatus is opened with a horizontal incision. After sufficient enlargement of the paraesophageal space, we can identify the posterior cardiophrenic lymph node via esophageal hiatus using a finger palpation. A small separate diaphragm incision is made in the diaphragm where the lymph node was palpated. We should be careful to avoid the pericardial injury during the lymph node dissection because this area is very narrow and dangerous due to the adjacent beating heart. Liver retraction, gastric depressing, and proper widening of the diaphragm incision are needed to obtain a better surgical field. Electrocautery and energy device should be used very carefully not to cause thermal injury. After confirming that there are no more lymph nodes remaining, we can close the diaphragm incision with 2 zero silk interrupted sutures. We used 3 stitches for closure. Finally, the enlarged esophageal hiatus is closed with 2 silk interrupted suture. We used just 1 stitch. We should avoid the tightening or narrowing of the esophageal hiatus. You can see that all the targeted cardiophrenic lymph nodes have been removed on the post-operative chest CT.